So, welcome to the fourth IPOPI webinar. Thank you all for joining the session and taking the chance to learn about this interesting topic. I am Martine Perjean, IPOPI President, and this is my pleasure to moderate this webinar sponsored by Octapharma. Today, we will explore the crossover between primary immunodeficiencies and cancer, and provide better understanding of both the correlation and the management. To address this theme, we have a great specialist with us, Professor Isabelle Meyts from the Department of Pediatric at the University Hospital Leuven in Belgium. Professor Meyts is the current ESID president and member of IPOPI Medical Advisory Panel. Welcome, Professor Meyts. So, how will this webinar work? Professor Meyts will soon begin her presentation. When she presents, you can post your questions on the webinar on the tab on the right of your screen. After the presentation, we will discuss a selection of questions with both Professor Meyts and Dr. Nizar Malawi from Necker Hospital Paris, who kindly has joined the webinar today. He will also answer some of our questions in written form, and for that, we say thank you to Dr. Malawi. But now, I would like to say to Professor Meyts, the floor is yours.
Thank you very much, Martine, and thank you very much, IPOPI, for giving me the honor and chance to talk to you about primary immunodeficiency and cancer, because I truly think that this is a field that we have to explore further, again, for the benefit of our patients. So I think it's important to realize that the idea of the intertwinement between malignancy and the immune system is actually quite old. So already in the early 1900s, there was Paul Ehrlich who said that in the enormously complicated course of fetal and post-fetal development, there must be aberrant cells that become unusually common. And fortunately, in the majority of people, they remain completely latent thanks to the organism's positive mechanisms. So probably these positive mechanisms were indeed the immune system and the immune effector mechanisms. And somewhat later in the 50s, there was the theory by McFarlane Burnett of the immune surveillance. And he said that it's actually by no means inconceivable that small accumulation of tumor cells may develop. And because of their position of new antigenic potential, they provoke an effective immune response with regression of the tumor and no clinical hint of its existence. So this was an important concept, and of course, in the terms of primary immunodeficiency with a failing immune system, one might think that a lack of immune surveillance is actually one of the more important mechanisms of disease in malignancy and primary immunodeficiency. And there was also in the 70s already the two-hit hypothesis with the study of retinoblastoma by Knudsen, who said that there's a clear difference between sporadic cancer and inherited cancer in terms of a second hit that needs to be acquired in the sporadic cancer cases. So we will further see that in the case of primary immunodeficiency, there seems to be another action going on, except for the immune surveillance. There's also the primary immunodeficiency intrinsic features that will predispose the patient to malignancy. Now, it's important to realize that this malignancy phenotype has become a major phenotype only since patients were surviving into adulthood and into the second decade, because before that, it was actually infection that usually prevented the phenotype of malignancy from becoming apparent. So it's really thanks to registry data and to accumulated evidence that we are learning on the increased incidence of cancer. And it's a fact that there is an increased incidence of malignancy and primary immunodeficiency, and that these cancers usually develop more early in life. We will look into some registry data, and I will also highlight some cancer subtypes that are important to primary immunodeficiency. And then we will investigate some mechanisms that can link the phenotype of malignancy to the genotype of primary immunodeficiency. And I will give you some examples before we close the webinar. So First of all, we need those registry data to really see whether there is an increased incidence. And I think one of the more recent works on this came from the United States of America with Mayer, looking into the USIDNet registry, where they looked into a cohort of over 3,000 patients and where it was clear that there was an overall increased risk, especially for lymphoma, of more than 10 times the general population, but also for skin cancer, times 3 to times 5, and for thyroid cancer. And looking into the sub-cohorts, because there was an overrepresentation of primary antibody deficiency syndromes and CVID, it were especially non-Hodgkin lymphoma, gastric cancer, and skin cancer that were predominant cancers. There was a little pitfall here. It is voluntary reporting, and the malignancies might be underreported. And also there's usually not a specific diagnosis provided. However, these are after the initial registries in the 70s from Australia and also from the United States, the ones that really show that there is an increased cancer incidence. And if you look at the general group, you might say that there is an increased risk of times 4 to even 2.6 times the general population. Now, what is interesting to see in this cohort and also in the future cohorts that we will study is that there is no overall increased risk of cancer because the most predominant cancers in the general population are actually not overrepresented. So it is not clearly a lack of immune surveillance that is really the culprit here. If we look into a smaller data set of the Dutch extraction of the ESIT registry, we actually see the same data. So 10% had a malignancy, and the relative risk was 2.3 times. And again, lymphoma and leukemia were quite predominant next to thymus and endocrine organs. So again, we see the same number of tumors and the same types of tumors popping up. This is also a very interesting study, especially for the CVID subgroup. It's still the most important clinically relevant group of primary immunodeficiencies in an Italian cohort study, where the increased risk for all cancers was 2.4, but for non-Hodgkin lymphoma, it was 14, which is an extremely high number. And also, let's focus on the data on the gastric cancer, which was in the early registries less well recognized that there's a huge increased risk for gastric cancers in these patients. And moreover, this can be rapidly progressive cancer, going very fast from almost undetectable lesions to an invasive cancer. So this is quite important. It's one of the major causes of death in the modern or in the CVID populations from these times. So I think it's easy to be convinced in this way, looking at the registries of primary immunodeficiency patients, but take it from the other side and go through a cohort of patients, for instance, with non-Hodgkin lymphoma, which is one of the predominant cancers in primary immunodeficiency. And if you look in that cohort, this is a child and adolescent cohort by the IBFM, you see that in a cohort of 230 children, there was actually, in the entire cohort, there were 213 children with a pre-existing condition, of whom more than 50% had a primary immunodeficiency. And here the sub-classifications of the primary immunodeficiencies were quite actually overlapping with the older data that we have. So it's Ataxia, telangiectasia, that is quite predominant. There's also XLP1 and Wiskott and CVID, and some less well-represented but very important immunodeficiencies like ALPS, STK4 deficiency, X-linked hyper-IgM, and also autosomal dominant STAT3 loss of function. So this again shows that if you also look at a group of patients with malignancy, it's really worthwhile and important to look into the underlying primary immunodeficiency diagnosis. So there would be an interesting question, so as to say, if you have a specific kind of tumor, what can we extract from that? And even, so if we look in all the tumor types that have been described in primary immunodeficiency, what stands really out is the lymphoma, and the non-Hodgkin lymphoma is actually the number one, usually B-cell phenotype and extranodal. followed by leukemia, also often T-cell leukemia, and lymphoma. And then, of course, the risk of carcinoma cannot be neglected. There's gastric carcinoma, skin carcinoma, and also bowel carcinoma. And there's more rare cancers that are more specifically related to one or another primary immunodeficiency phenotype. But I think it's important to realize that some specific tumors might be associated with some specific primary immunodeficiencies. But think of lymphoma and leukemia as the really number ones, followed by carcinoma. So we were talking about the link between primary immunodeficiency and cancer, and thinking away from the immunosurveillance theory, because we obviously see that lung cancer, prostate cancer, breast cancer are not overrepresented here. It's more about what is really in the genes that are affected and defect in primary immunodeficiency patients. And this is, I think, a wonderful study from the group of Ghent here in Belgium, is that where they look, actually, I cannot show it with a pointer, but if you look into the sphere, so the sphere on the left side, if you watch the screen, is actually the sphere where all in the outer circle are all the genes that are now really related to primary immunodeficiency. And if you go to the inward circle, you have the cancer predisposition genes and the genes related to cancer. And you can actually see all the dots in the circles representing the overlap. So it's really the crossroad between primary immunodeficiency and cancer. Some genes that are really relevant, for instance, CTLA4, where in a recent cohort study by Bodo Grimbacher, there was a 13% chance of developing cancer. This gene is not yet in this panel, but it's important to realize that we have this overlap already and that it will be an evolving spectrum for sure. Also, what is important, if you go to the second circle on the right, these are actually the somatic mutations that we find in genes, actually that we find mutated in patients with malignancy outside primary immunodeficiency, but that we know as genes that are causing immunodeficiency if they're germline mutated. And there's plenty of examples. For instance, there's Icaros, there's STAT3, there's JAK3. So all these genes are really important for both cancer and for primary immunodeficiency. So I think there is absolutely an intrinsic risk of malignancy in the germline mutations of many primary immunodeficiency genes. Another quite interesting way to look at it is actually what I extracted from a beautiful review from Fabian Hauk and Markus Seidel in the Journal of Allergy and Clinical Immunology recently, is that different mechanisms across primary immunodeficiency are actually contributing to increased cancer incidence in primary immunodeficiency. And if we go from the top to the bottom, you can actually see that, for instance, a problem in stem cell and myeloid compartment development can be a cause of cancer in PID, for instance, in Schwachman syndrome, GATA2 deficiency, or even in severe congenital neutropenia. And then on the right, you have the lymphocyte development problems in the apoptosis pathway defects, and you have the lymphocyte cytotoxicity defects that are predominant in many combined immunodeficiencies and also in CVID. You go to the DNA repair defects, where, of course, there's the obvious condition of Ataxia, telangiectasia. But there's also, not to forget, the oncogenic viral infection. And if the patient, due to a disturbed effector function, cannot, for instance, beat EBV virus or HPV, then a viral induced tumor may develop. And it's important to say that in the majority of for instance, lymphomas, EBV seem to play a role, at least in 50% in most of the conditions described. And as I said previously, tissue inflammation, the skin, the bowel epithelium, if there's chronic inflammation, this is also predisposing to cancer development. It would be too simple to ascribe one mechanism to one immunodeficiency. So in most of the immunodeficiency syndromes, there's many mechanisms at play. And so there's usually a combination of factors that lead to the malignancy in these patients. So I will highlight some of these disorders because I think they're important because they're easily forgotten, or they are just so important because there are so many patients. For instance, here, the DNA repair disorders, you can see in this slide different systems of DNA repair that are active in our immune system. And I think it's important to realize that a good working immune system needs a lot of DNA breakage and recombination, as you know. So you also need the tools to repair that. And if you have a problem in the repair of this, this will quite intelligently cause not only immunodeficiency, but also a problem and an increased risk of cancer. You see here in the top, Ataxia, Nijmegen breakage syndrome, Bloom syndrome, Fanconi, to name a few, but also Artemis deficiency, Cernunnos XLF. Ligase 4 that are all related not only to immunodeficiency, but also to a problem with cancer. So looking into AT, and I'm glad that Nizar is also here because he, together with his colleagues in France, published a beautiful overview of cancer in ataxia. I think it's really important to realize that this is an underestimated condition, and I think it's still important to realize the evolving phenotype of these patients. It is autosomal recessive. The incidence is believed to be 1 in 30,000, depending on the population. But the initial symptoms can be very mild, and you can only notice the oculomotor apraxia and maybe some nystagmus, but the rest of the phenotype needs to evolve. And it's so, in a patient developing with a phenotype of lymphopenia, autoimmunity, and infections, I think it's always important to think of ataxia as a potential cause. And I think it's important to realize that ATM is absolutely the central molecule in the start of the cascade of DNA, double-strand DNA sensing and hence repair. So it's central to the pathway. And if you look at this figure from in the right side, the right under corner, so many of these molecules here are actually important for many different primary immunodeficiencies, but also in cancer development. So it's an absolutely important molecule for DNA repair. Cancer predisposition is 25 to 35% lifetime risk in these patients. And there's even a 1% per year incidence of malignancy from 10 years on. And again, the represented group is the lymphoid tumor group with TALL and B-cell lymphoma that are quite prominent. And in adult patients, also solid tumors are more reported. So I think it's really important to realize that ATM and mutations in ATM and AT as a disease is really a disease to consider in any patient presenting with a Burkitt lymphoma or an unusual leukemia if the diagnosis has not been made before. And I think this still happens, unfortunately. And then this is the study where Nizar was actually also leading this study. So it's a beautiful study, a recent study, showing that in the cohort of 279 patients with AT, again, 25% developed cancer. So the numbers are quite equally between the different cohort studies. But I think it's important, this study added to the data that the mutation type is not associated with cancer incidence, but more so with overall survival. And I think this is really important, that we learn not only to fine-tune the disease, but also the different mutations within the gene that is affected, and to try and make a prognosis for the patients involved. So what about therapy? Because that was also one of the outset. Of course, therapy for ataxia has been cumbersome, and there's actually no, at this point, no curation provided for these patients. But I just want to highlight a recent study that shows the outcome of stem cell transplantations, because this is a question that we often get. This was for AT and related disorders, as you can see them here: XLF, Nijmegen breakage, ligase 4 deficiency, and ataxia. And you can actually see for the entire cohort, there was a survival of 69%, but let's see in red the numbers, it's only 25% survival for the patients with ataxia. So I think that is an important number to realize, and it's important to realize that the conditioning regimens we are using are quite toxic, and that we need to look further into this. So I want to now highlight ALPS. I will go a little bit faster through these slides. So autoimmune lymphoproliferative syndrome, as we all know, a syndrome with uncontrolled lymphoproliferation with autoimmunity. And we all know the genes involved, Fas ligand and caspase-10, and somatic mutations also. What I think is important is that we realize that these patients can have, apart from the autoimmunity, also very severe and early onset of lymphoma. So this is a nice natural cohort study from the NIH, where it really states, and that is my important message, that lymphoma can be the first clinical presentation of autoimmune lymphoproliferative syndrome. There's a male predominance here in this cohort, but I think it's important to just state it there. If you look at the lifetime development and the risk of lymphoma in ALPS, that we actually should consider thinking of also screening for this and other disorders in childhood lymphoma. GATA2 deficiency also, because it's really on the crossroads of primary immunodeficiency and cancer. So you know that GATA2 deficiency is caused by heterozygous germline mutations leading to haploinsufficiency of GATA2. GATA2 is an essential transcription factor in the hematopoiesis, and if there's haploinsufficiency, not only do you get a phenotype of immunodeficiency with severe viral infections and so on, but you also have a very much increased risk of cancer. And the cancers that you see are actually in the spectrum of MDS, with acute myeloid leukemia, with myelomonocytic leukemia, but also not to forget the HPV-related cancers. And I think this is really important. So we have to keep that in mind, that in this condition, we are going to learn more and more about the lifetime risk of cancer in GATA2 deficiency. And I want to highlight here in red also a beautiful study from Jean Donadieu, showing that actually in this MDS cohort, the lifetime risk is actually very, very high to have MDS or a related problem. It's even 81% at the age of 40 years. So I wanted to highlight this as well. And finally, the inadequate control of oncogenic viruses, especially EBV as the big culprit virus there, should not be underestimated. And I want to show here a beautiful paper, one of the many reviews that Stu Tanguy, and based on his work on EBV for a long time, has written. And you can actually very nicely see all the molecules that are involved in the different immunodeficiencies that we know, XLP1, MECT1, and also the different diseases like APDS, where you see that an inadequate effector function of the CD8 T cells and an inadequate T cell priming actually go on to uncontrolled EBV-induced lymphoproliferation with lymphoma development as a consequence. So, of course, it's impossible to go into detail for all of these diseases, but again, XLP1 is a disease where the risk of developing lymphoma is as high as 25%. So these are really not conditions that you can neglect in terms of malignancy. So I realize this is only a little, let's say, extract from all the literature that is on malignancy and primary immunodeficiency. And I think that it's a sign that there's more interest from the society, from the patients, from the medical doctors, and also from the hemato-oncologists, that malignancy is an important phenotype of primary immunodeficiency. It was the topic of an entire conference, and we see that many working groups are getting together to know more, and especially to find better ways to not only to manage these patients, because of course often you need adapted regimens of chemotherapy, but it's also important for us as immunologists to screen for malignancy, to be aware that not all complications or signs that we see in patients are related to infection, but that we must actively think about malignancy and cancer as an underlying diagnosis, and that we have to also have increased attention for the personalized treatment of these patients if they develop a malignancy. And I think there it's extremely important that hemato-oncological societies and primary immunodeficiency societies get together and discuss and set up studies. And as I said, many initiatives are already on the way, and I'm very optimistic about this. And I also think that the hemato-oncologists should take the momentum to start really screening all of the patients with immunodeficiency, I mean with potential immunodeficiency. And having said that, we might even think as the genetic paradigm of infection, we might also think of the genetic paradigm of malignancy in childhood. So I think that there is really an opportunity here to do more and to look better into the underlying predisposition of patients with childhood cancer at least, but also with lymphomas later in life and other types of rare cancers. And with this, I want to thank IPOPI again for challenging me with this webinar. And I hope that it was clear and that you learn something and that you can take this further.
And we want to thank you, Professor Meyts, for this great presentation. It is certainly an interesting topic that we will be hearing more and more about. To follow up with this, we will turn our attention to questions from the audience. With that said, I would also like to welcome Nizar Malawi, who just has joined on stage. I can't see him, yes. And to help answer some questions in written form.
Hi.
And hi, Nizar.
Hey, everyone.
And as a first question, I would like to ask you, there is a question about the correlation between CVID and cervical cancer in women. A person from Australia says that at our recent conference, we were astonished to find that quite a few women, different age ranges, had cervical cancer. Also interesting was that most of these women had also had EBV. So what do you think of that?
Me?
I don't know, yeah, maybe Isabelle, yes, to begin
Actually,
with. And if you want,
cervical cancer, as we know, it's an HPV-induced cancer, almost always. And HPV is a troublesome virus to deal with if you have a flawed immune system. And to be honest, because I was interested in this also after studying patients with WHIM syndrome and also in patients, for instance, with GATA2 deficiency, there is very little literature. It's usually disease-specific cohorts that you can see, but there's actually, if you look into cervical carcinoma, it's never really looked upon from the angle of disturbed immunity. There's some beautiful data from virologists also that show that the mucosal immunity is defect in these patients at high risk. But I agree with a question from Christine that it's actually an underexplored part of malignancies. And I fear that we are missing a lot, especially in younger women developing cervical neoplasia. And I think we need more screening. And I think we need to also, if it's not installed yet, but Australia has done a great job there, that we have to really look into perfect immunization of the patients. I realize that this is not a good answer to the question, but I think it's an area that is not explored well. But I do believe that there's a link with the defective mucosal immunity. And some syndromes like WHIM syndrome, like GATA2, and all the combined immunodeficiencies, actually, if the patient survives, there's actually still the mucosal immunity problem, DOC8 deficiency, all those different combined immunodeficiencies.
Okay. Yeah, it's not an easy question anyway, this PID and cancer to be addressed. Another question from Josie: is there a case for testing also cancer titers at the first consultation? I don't know who wants, maybe Nisa?
Sure, yes.
Nisa, would you like to, to a word on this?
So some cancers can be screened, as Professor Isabelle Meyts just mentioned. There are different ways of screening, and one of them is to have some blood tests. So, for example, ovarian cancer might be, there might be a biomarker. It's not always sure that it's positive. I mean, it's elevated in case of cancer in the general population. So we don't know if it would be elevated or not in the PID population. So I think at the first consultation, that would not be necessarily relevant to do it, because there are many other things to to check, such as the lung function, the liver function, the kidney, but for sure in the following consultation, there might be some testing that can be done regarding some cancers that might develop. And obviously we should look into which PID specifically we're talking about, because as Isabelle shown, not all PIDs will develop the same kind of cancers. And on top of that, there are also the screenings that are widely performed in many countries regarding other, in the general population, regarding the mammography, the cervical swab, and so on and so on, that should be performed in PID patients anyway.
Thank you, Nisa. We have another question for you, maybe Isabelle. Do we have data of patients diagnosed with PID after screening sent from oncologists because of to diagnose a PID?
Actually,
in short,
I don't know. I really don't know. I didn't find those data. They must be out there somewhere. I think there's the smaller cohorts of specific cancers. That's true. And especially, as I mentioned, also the non-Hodgkin lymphoma. So all the different cancer sub-registries, they do start looking into it more and more. But it's recent literature. And if you would say like center specific, for instance, MDS patients, are they all screened for underlying PID? I don't think so. They look for somatic mutations especially, and if, of course, in the somatic mutation screen you pick up a GATA2 deficiency, then you will go further and look into germline mutation, of course. But as an automatic system, I wouldn't say it's that widespread yet. But I think there is absolutely, in the time of rapid molecular diagnosis, there's absolutely room to do that. And I think that will be absolutely the next step.
Yeah, it is interesting to see what we can do in the next future. For you, maybe Nisa, because you are the registry champion, we have a question about how many Ataxia telangiectasia in the ACID registry. I'm sure you can't answer, but as a principal, have you any answer? Is it possible to know?
Well, actually, I was looking at the data, because this is a very specific question. I think it's great. So among the European Society for Immune Deficiency registry, so this registry has been set up in 2004. So 16-year-old, so it's a teenager registry. There are 30,000 patients, and out of these 30,000 patients, there are 836 patients with ataxia telangiectasia that have been included. So it means that there are for sure many more other patients with ATM, but that would be, the minimal frequency. So almost 1,000 for sure.
Okay, thank you very much. And another question on the relationship between oncologists and cancers group. Do oncologists work with all cancer groups? It's a question from Josie.
Well, usually there's a very strong interaction between cancer specialists and the different cancer study groups. Very strong interaction. And I think, I'm sorry, there's usually some geographical, let's say, predisposition to work with one or another protocol, but all those data are very consistently followed and very consistently grouped. So these data are available, and usually also material of the tumor and DNA, etc., are stored. So it could even not be so difficult to go back in time, and for sure to do something prospective.
And now, from a single patient perspective, patient with PID, is there any advice you could give to prevent cancer in PID, or to diagnose it or as early as possible? What would you say? Isabelle and Nizar, up to you, or Nizar?
Yeah, Nizar.
Okay, I think it's a very important question. I think we cannot, just provide one simple answer that will be, fit all PIDs and all patients. But what is very important is that any patient with primary immune deficiency should be, screened for cancer, or at least cancer should be, talked about, and be kept in mind. So obviously the clinical examination, if you feel a lump, if you feel an enlarged lymph node on your neck, maybe, or in your armpits, or at the on the top of your thighs, for example, it should be something transient and benign. But if it has some symptoms such as a rapid growth, if it's painful, if it's kind of hard when you press it, or if you feel like you're having night sweats, or these kind of symptoms, you should definitely be examined by your physician, and especially your PID physician. That might be a sign of a hematological malignancy, mostly lymphoma. But again, it could be just maybe an infection, or just something different. So, but at least it should be checked. So every time you get under the shower, for example, you or your child should get used to do it. In some instances, for example, in Ataxia, telangiectasia, there are some things that should be avoided. For example, X-rays. Except in case of an emergency, like a pneumonia or pneumonitis, and a chest X-ray could be done, of course, in order to know what's happening. But many X-rays just to screen for a cancer should be avoided. So it's really dependent on the primary immune deficiency. Any mole on your skin should be taken seriously and should be looked up by a dermatologist. The blood test, again, as we alluded to, in the liver, for example, if there is some kind of elevated liver enzymes, again, could be different different things, but one of them could be some nodules in the liver, and then an ultrasound could be performed just to look for nodules inside the liver, and maybe perform some biopsies if there is nothing else to do, just to provide a proper diagnosis.
Mm-hmm. Speaking of ultrasound, we have a question from Sophia asking how often should we perform this in PID patients? It's a very specific one, but you spoke of that, so I try.
No, there shouldn't. There is no. There is no specific rule to perform an ultrasound of the, let's say, of the abdomen, or on a regular basis. There should be, some symptoms and some, gut discomfort, or maybe some pain or elevated liver enzymes, for example. But let me come back to the previous questions, because as Isabelle alluded to, some recent works, researches have shown an elevated risk of gastric carcinoma, especially for adult patients with the CVID. So for these patients, we should probably be more proactive in screening for that. And usually it's going through inserting a tube in your mouth and then the esophagus, and then look into the stomach mucosa just to look for some tumors and maybe biopsy them, just to make sure that this cancer is taken at the earliest stage as possible.
Mm-hmm. And Isabelle, would you have some other things to add to that?
I think as a pediatrician, we are a little bit unprone to technical investigations and screening tools that are technical. Mm-hmm. I do think that there is maybe room to have like a 1 yearly. This is dangerous what I'm saying, probably, but I feel like I'm growing towards it, at least in adolescent children, in adolescent patients, to go to a yearly, like let's say a workup. You see the patients regularly, but I think it's wise to at every visit check for signs and symptoms and signals that would allude to a potential tumor. But I think if in doubt, I think a screening with an ultrasound does make sense to me. And especially as patients grow a little bit older and into adult age, without saying that this is perfect and that this is evidence-based, etc., I do think that there is room for giving the patients once per year a decent, standardized way of following them, as actually is being done for patients with almost all other chronic disorders. And I'm not saying that we are speaking here about subclass deficiency only patients, but for instance, as you say, the CVID patients with complications, I do think it makes sense to have a yearly workup day where you do pulmonary function, where you do a good questionnaire on the gastric complaints, etc., and where at the slightest hint you go a little bit further. Because that is actually also one of the key messages from many of the reports, is that these cancers can be aggressive, especially the gastric cancer. And I think that there's room for an adapted screening program in immunodeficiency patients. Is this evidence-based? Not at all. This is more of the clinical feeling that I have had in the very recent years, because I'm relatively young still. So it's my recent feeling that we might be more proactive than waiting for what we are going to find. But that's maybe a wrong idea, but this is what also patients...
No, I think... I think I echo your comments, Isabelle. We should be more proactive and maybe work on gathering more data and providing guidelines.
Yeah. So I think that we come now to the end of this webinar. I have to say that it was the first time that we dared addressing this issue, because it's a tough one. And I think it was a great webinar, and I would like to thank both of you for that, and also Octa Pharma that made this webinar possible, thanks kind donation. So on behalf of IPOPI, thank you, a big thank you to both of you, and to Professor Meyts, to enlightening presentation, and for all the answers you provided. And also thank you to Nizar Malawi, of course. Thank you to all of you for attending this IPOPI webinar. You were numerous, very happy about that. And please note that you will be able to see the recording of IPOPI TV on IPOPI TV within a couple of days. And we encourage you to share it as much as you can to those who you think will benefit from it. Have a nice day, keep safe. Bye-bye.
Bye-bye.